I propose just to start with the first lecture, which will be given from Professor Uvar. It is about left main PCI and how to build the optimal strategy for PCI on the left main, especially distal left main. Yves, the floor is yours.
Thank you, Dobrin. So my talk, as it was said, left main PCI, building an optimal treatment strategy. Of course, my optimal building strategy. So this is an unproposed algorithm by Davide Capodano. When we have an isolated left main or a left main plus a single vessel, it is not useful to do SATA score because this is virtually never high, and the equipoise of PCI and cabbage in hard outcomes is reached. And PCI is preferable because this is less invasive with a short hospital stay, early mental and physical recovery. When you move to more complex left main plus 2 vessel disease, left main plus 3 vessel disease, then you have to calculate the syntax score. Again, if you have between 0 and 22, this is for PCI. And when you have more than 22 and even more to 32, then to have to do the syntax score calculation, you have, I said that. When you have more than 22, you have to perform the syntax score, which gives you the mortality at 4 years for cabbage and for PCI. When the syntax score is in favor of PCI, you have to perform PCI. When the syntax score in favor of cabbage, you do a cabbage. When you have a syntax score which is equal, then this is the place of the art team to discuss the case with surgeons regarding operators' experience, technical aspect, and patient choice. So you know all this syntax score, old one. You know the syntax score 2 gives a mortality at 4 years in PCI and surgery. And there is now a new syntax score, 2020, that I've never used, but this is online, I think. And you have to remember that in a center, surgeon can be good, better than interventional cardiologists. On the contrary, so you have to also to take into account in your center what are the results of both teams. This is from syntax, and our place in Massy is exactly here in the middle. So good surgeon, good interventional cardiologist. So the art team discussion is certainly to plan techniques in surgery and PCI and to respect them. For surgeon, to respect the number of grafts. For PCI, to be sure that you will open a CTO. Center, you have to take into account the result of surgical and interventional teams and take into account of the individual surgeon or interventional cardiologist. So optimal strategy for left main stenting. In fact, we have 2 main strategies, which is the DK-CRUSH 5, was proposed by Chaoyang Chen. And you have to see that on the left side, there is no difference in mortality, but with a trend for better result with DK-CRUSH. But when you look at all-cause deaths, you know, this is the most important for the patient. You can see that there is a trend for higher deaths in the DK-CRUSH group. When you look at the curve of target lesion revascularization, of course, this very curious end of the curves have been studied, and this is very clearly related to a systematic angio performed at the time of a clinical endpoint, which is not a good idea. So, on the contrary, we have EBC main, was performed in a population completely different. I have to say much more simple than the Chinese one, and you can see that there is a small trend for a better result in at 1 year in the single stenting strategy. In a sub-study of Excel, it was shown that the death MI stroke at 3 years was lower when using provisional versus 2 stents. And it is the same for death MI stroke and revascularization at 3 years, again in favor of PCI. I think this slide is important because when you have very complex patients, you have to think about staging. Staging is saving life, as it's shown here at the bottom, here, saving life when you stage a procedure. And also operator experience and volume of operators, also very important in this study by Bo Zhu in China, showing that if you have experienced more than 15 patients during the last 3 years, you have a reduced rate of cardiac death at 3 years. So you are saving life. So complex cases are for experienced operator. So building an optimal treatment strategy, you have many kind of patients. You have the patient refused by surgeon. I will show you a case. You have to take into account the number of disease vessels, number of lesions, complexity of lesion. Complexity of lesion is very important because you can anticipate some difficulty in handling and you can anticipate also a longer ischemic time. The fact that the left coronary artery is dominant or non-dominant, or there is a contralateral occluded RCA, the presence of collaterals, ejection fraction, hemodynamic stability to choose for support, and of course, again, the experience. So this was seen, I remember, it was in the 90s, was seen by one of my fellows as a high-risk procedure. But in fact, this is not the case. You can see that injecting the right, we see all the left coronary artery. Of course, it would be a very bad idea to inflate in this lesion in the right. And this is typically for me the case for a young, good fellow. It was done by the fellow successfully without any difficulty. So some cases, quickly. Left main PCI, neuro PCR. This is a severe case of left main stenosis. 111, we see on the right that circumflex ostium is also touched. And it was prepared, but I want to focus on this preparation. Sorry, just back. This preparation. You see that the balloon here is not inflated more than the LAD. It means that it was not correctly prepared. A good option should have been done a pot without stent in the proximal part in the left main. So look at the implantation of the stent. Again, on the right, you see that the stent is not deployed. And now you can look at the result. Two of my colleagues, I was not proud, and they were also not happy. And to save that, they did a pot to open more the left main, which was not done during the stenting. And after that, you saw that on the right, there is some contrast going to the circumflex, was not crossed with FC, SI medium, but was crossed quite easily with Fielder HT. So after that, it was kissed, and this is the result. So it took 20 minutes to have a good result in the SURF, but the lady was very well. Difficult access side branch, 101. So this is not so frequent to have this very eccentric lesion. You have to use on the right what we call the reverse wiring of the side branch. You make a long loop and then you pull slowly, you pull, and you can see that now the wire is in the circumflex artery. And of course, as you have seen, this lesion was a left main lesion, no LAD lesion. Of course, here in this situation, you have to do an inverted provisional. I mean, to stand from left main to circumflex artery. Was done, was pot, was kissed, and this was the result. And if you look here cautiously, you see that you have projection of the metal LF main to circumflex, projection of metal in the LAD. My friend, associate Thierry Lefebvre, was telling that we are stenting both vessels with a single stent, a bit exaggerated. Patient refused by surgeon. So in this situation, sometimes you have no other solution than to do a reasonable and complete revascularization. So this is the case. This lady had a cancer, had radiation, and she was strictly refused by the surgeon. So score 38, surgeon refused absolutely, so we decided to do a PCI of the proximal RCI stenosis and PCI of left main and diagonal. So this is after treatment of the right. You see that you have two more bifurcation lesion distally that we left. And this is in 6 French, 3 wires, circumflex, LAD diagonal. Preparation of the left main on the right. And then stenting on the left, from left main to distal LAD. So the provisional crossover stenting in front of branches with wires. Then on the right the balloon was pulled a bit in order to create a second diameter proximal to the diagonal. And after that, we use a real good big balloon to do the pot in the left main. So this is the result after crossover stenting. You see tight lesion on the circ, tight lesion on the diagonal. But they are here, they are not occluded, because we choose the stent from left main to LAD from the diameter of the LAD. So after that, we did an exchange on the left of wire from LAD to diagonal, and of course then diagonal to LAD. And we did a kiss LAD diagonal, a kiss left main circumflex. And we saw on this control, circumflex is at the top, we saw a dissection in circumflex, so we implanted a stent in the circumflex. This is the practice of provisional stenting. And after that, we did, of course, a kiss in the left main with the result on the right, which was acceptable for this lady. Incomplete, but acceptable. And you can see we did the last spot, and what we see is here with stent enhancement, we see quite clearly the 3 diameters of this stent. Distally is small, a bit bigger, proximal to diagonal, and big in the left main. Final result. A bit of creativity sometimes is necessary. This patient was a young man. He had cardiac arrest out of hospital. Reanimation was quite long, and we were really concerned by brain of this patient. So, of course, he received adrenaline. The radial was small, so I used a 5 French. And I decided, despite the lesion you see here on the intermediate, on the circumflex, I decided to do a short stenting of the left main only. So this is not provisional. And if you look at the end of the injection here, you see the stent is stopped exactly proximal to the circumflex. And I left it like that. I have not treated the circumflex. And unfortunately, this patient died for cerebral death 4 days later. Inverted provisional strategy. You have seen one already before. This is another one. It seems that this is an unstable lesion on the left main, maybe some calcium, but I would say more unstable lesion. And the LAD seems, proximal LAD seems to be not very stenosed. So we discussed intra-aortic balloon pump, but I considered that it was not so risky to put a feeder XT in the circ. After that, I opened toward the circ. I put a stent. I did a pot. I did a kiss. And now, on the left, this is the result without stent on LAD. And we left it like this. It's not necessary to put a stent in this vessel, which is not severely stenosed. Left main trifurcation. This one is a bit spectacular. This is, you can see on the left, complex lesion, left main LAD, circumflex, first marginal. So I did a crossover stenting with protection. I did a kiss with the circ. You see the result on the left. So I decided to exchange a wire, pre-dilate it towards the first marginal. And finally, I implanted the stent from left main to first marginal, if you can see on the left. And the result on the right. And after that, I change wire again to do a kiss between first marginal and circumflex and distal circumflex. The result on the right. And I was not very happy with the result of the distal circumflex, I implanted another stent followed by a kiss. And this is the final result. So it seems to be complex. In fact, you have to follow the flow, you know. You begin proximal and then you go distal. Left main double stenting with provisional strategy. This lady is a colleague, a friend of mine, was of my corresponding cardiologist. She had previous Hodgkin disease, which is known to create a very strong stenosis on coronary. She has another one on the right. And she arrived after a pain. She was escalating in Indonesia, and she arrived with a very positive stress test. So I put 2 wires. It's the beginning of everything in bifurcation stenting. I pre-dilated, which was not very effective. You see on the right, I put a stent, crossover stenting, 3.5, did immediately a pot on the left main. You can see that the circumflex is still patent. In fact, if you choose a distal diameter, the risk of side branch occlusion is very small, of course, and never use either this is for financial result, but also I don't want to use a media-to-media of IVUS that will lead to occlusion of the side branch. A kiss was done. This is the post-kissing. And you can see that we have, as we re-enter distal towards the circumflex, we projected very clearly some metal towards the circ. And I decided to do a perfect stenting, I mean implantation of a stent in the circumflex, followed by kissing and by pot. And this is the final result, which is very good. My friend is doing very well since 5 years. And we'll go very quickly to the last one. This one is a bit complex, so you may think about, personally I was thinking, do I have to go to left main to diagonal or left main to LED? I put 3 wires. You know, the flow is coming. I put 3 wires. After that, I put crossover stenting from left main to LED, diameter from LED, followed by pot. You know, again, I push the pot inside the LED to cover the proximal part of the LED, then a true pot on the right, and a kissing with the diagonal, a kissing with the circumflex. And again, we see the 3 diameters here very clearly. And this is the final result. So probably I'm late. So I will go to the conclusion. You understand that I'm a fan of provisional stenting. I never did. I did 1 crush, but was not intentional in the 90s, and I stopped culotte also at the same time. And so I'm using absolutely always this strategy. And this is a conclusion from David Hilding-Smith, doing the same as me. For complex left main bifurcation, you can use provisional or systematic dual techniques. Provisional resulting in 2 stents is equally applicable. If you are doing complex left main bifurcation stenting, you have to learn the technique and apply it rigorously and carefully. The technique itself is less important than its application. Especially if you do a low number of left main stenting in a year, let's say 15, if you want to absolutely to share in 2 techniques or 3 techniques, 5 with a culotte, 5 with a decay crush, and 5 with a provisional, then you will be very bad in 3 of the techniques. Thank you very much.
Thank you, Yves. That was amazing as always presentation in your style. Actually, this is the modern approach for the left main, at least in our center. I don't know, Ravi, how is in your site?
So a great presentation with some fantastic cases, but maybe you brought your best cases here. What is interesting is that you mentioned all these other 2 stent strategies. And those of us that have gray hair and have done this for a while have made it very simple. So your attitude of doing provisional stenting alone is what I tend to do also. And even when I do provisional stenting, it's mostly the tap technique rather than Coulard or anything else. Because that seems to work the best, both in terms of stent thrombosis and in terms of restenosis. The one question I wanted to ask is because there's a lot talked about intravascular imaging, especially in left main, and some of us who have experience can, by angiography, decide what size stent we can use, and we make the procedure simple and less expensive. So what is your experience with that? And second is the side branch, how often, I mean, if you see some plaque shift, which is moderate amount, especially in the circumflex, important territory, what is the role of FFR in your practice? Does that play a role?
Yes, two interesting questions. The first one is about IVUS. So to be very clear, in France we are waiting for, but today we don't have a reimbursement of IVUS. So we developed techniques in order to try to replace IVUS. And the problem for me, using IVUS or not, is to choose the diameter. I mean, the three diameters have a functional importance. So bifurcation is not a big tube and a small tube. This is 3 diameters. And this is very important to respect it for technical aspect, as I showed the first case, and also for the follow-up of the patient. I think it's play a role in reducing the neooptimal hyperplasia on the long term. So I have seen in China, especially by Xiaoliang Shen, I have seen one case which was a 1-1-0, so nothing on the circ. The lesion on the proximal LAD was remodeled. He took media to media and he closed the circ. So media to media is a big, big mistake. So now I convinced probably Gary Mintz. He says now, no question, don't do media to media. Try to find a normal segment in the cell, in the vessel, or calculate. If you have 3 diameters, you can calculate what is the normal diameter. So this is important. You can do, you learn a lot of things with IVUS that I don't know. I don't know at the end. I'm not absolutely sure that this is well opposed. I try to do it, but I imagine it is, but I'm not the proof. And IVUS for this is good, and OCT also. For the second one is FFR. Something that very important that was taught by Bon Kon-koo in Korea. He showed a lot of cases of left main with a tight lesion on the circumflex. He did FFR, and most of them, when the circumflex was normal before the procedure, most of them were negative. Even if you have 80%, 90%, most of them are negative. Why? Because you are creating a carina shift. This is related to carina shift. When you move the carina towards the side branch, you move the vessel from a circle to an oval, or sometimes a slit. But it decreases the surface only moderately. And this explains why it's not positive with FFR. So personally, I try to have something presentable, I try to have something that you can show without discussion to the corresponding doctor, because it's difficult to convince them that this 80% lesion is not dangerous. But take care of this. Don't think that because there is a stenosis that will be stenting. This is not true.
Is it working? It is not even when there is a carina shifting. Even it is not elliptical or oval. It is much more complicated because it is oval. Is something like that, but you have also 2 shoulders of this oval. Actually, the area is even larger than oval. Exactly. This is oval, but
crescent.
this is
a crescent,
yes, like a croissant. And it is larger as an area, and actually, I showed in 2018, we made a theoretical calculation, and we showed that the area is more than 40% larger than what you see if you calculate area based on circular or elliptical formula. When in the these deformable models, you know, which we used just to explore what is the deformation of the vessel, not the plaque, but the deformation from stent of the vessel, and the area is much larger. So you can leave it if the vessel before stenting is not there is no much plaque or much stenosis, nothing happens with these vessels.
If you are very rich, maybe people will go with FFR. So if they have an FFR, which is, you know, 92, they won't do anything. So
the problem
personally, what I'm doing is nearly always I'm doing a kissing. A kissing is not to treat a lesion which is not here. It's just to position the carena in the middle of the flow, because the carena is sharing the flow, and that is submitted to the high shear stress. So if you put the carena in a good position, you don't treat a lesion which is not there, but you are reconstructing the anatomy, I think.
The more, and what we demonstrated in 2016, that practically you can do intercoronary ECG, and if it is okay, you should not anything, even FFR. You don't need to do anything more, and this is the less expensive technique to achieve a good, functional, reasonable, let's say, result. But after following this patient during the years, because we started with intercoronary ECG with 2012 and 2014 with the FFR and ECG, and we found exactly what you say. In future, some of these big vessels they had a disease, and then recrossing, if you don't do kissing, is very difficult in later years. And now I'm doing exactly as you said, no matter is it diseased or not and how it looks, low pressure kissing just to oppose the stent struts, because we don't, especially for the large side branches more than 225, 24, especially more than 224 millimeters, we do kissing just to ensure the access to this branch in future.
Yeah, we had problem like this.
This is not a treatment for.
Rotablator, yeah.
Yes, this is not a treatment for during the PCI, but for the future.
Thank you.
Excellent discussion. I think we should go further with the next presentation. The next presentation is going to be practical approach to calcified coronary lesions, role of the invasive imaging in decision making. This lecture is going to be delivered by Professor Nair. The floor is yours.
Thank you very much for that introduction. A great pleasure to be back in Sofia, Bulgaria. Thank you to the organizers, especially Valery, for inviting me. This is my second visit here, and I'm glad we saw some snow last night, because this region has been deprived of some snow. So I'm doing an ad hoc presentation of the practical approach to calcified coronary lesions and the role of invasive imaging in the decision making and how we treat these calcified lesions. First, I would like to present a case that will illustrate certain things that I will be discussing very shortly. So this is a very large right coronary artery, as you can recognize. I'm trying to use the pointer. Okay, here it is. So we see that there are two lesions, as a matter of fact. One is more proximal, seems more severe, and probably responsible for this patient's exertional angina. There is also a lesion further distal, which is at least moderate, but most of us, when seeing these two lesions, are inclined to go ahead and stent both. What I would like to point out is the fact that when you look at this dominant right coronary artery without any contrast, there apparently does not seem to be any calcification that is silhouetting the vessel. We often depend on that appearance to comment on whether the vessel is calcified or not. So I would like to bring that and discuss that point later. So what was done was first the distal lesion was stented and was stented successfully, not a problem. And then the stent balloon was used to try and pre-dilate the proximal stenosis. And what you can see here is that semi-compliant balloon still has a significant waste on it, and no matter how high pressure they have gone. So at this point, this case was done by one of my colleagues. At this point, they decided to do intravascular imaging with a phased array ultrasound from Volcano. And if you follow along, what you will see is, I have to play this again. I don't know if I can play this again. At this segment, which is distal, what you can see is somewhat fibrocalcific plaque here. There apparently doesn't seem to be much calcification because, as you know, on intravascular ultrasound, whenever you have calcification, there is shadowing behind it. So this is fibrotic plaque, but there is no shadowing behind it because the density of the calcium will look the same, but there will be shadowing. Now this image went by very quickly, unfortunately, and what you may have noticed is that there was circumferential calcification in a very short segment, and there was a calcific nodule in one other segment. So after this intravascular ultrasound was done, and there was lack of full, complete expansion of that balloon, it was decided that this lesion needs to be treated further with some other technique in order to enable the vessel to be expanded further so appropriate stent expansion could be done. Otherwise, it is hazardous to put a stent in there and not have the stent fully expanded. So a lithotripsy balloon was used, and you can, if you follow closely, you can see that the balloon is fully dilated. And so that was felt to be a success. Follow-up angiogram was done, and if you look very carefully, the lesion seems to be dilated. However, there is a little bit of dye extravasation around that lesion that was dilated with the lithotripsy balloon. If you notice carefully, there's some dry extravasation. It is not a perforation because it is not entering any free cavity, but clearly there has been a deep dissection, and that's a point I will make further. And then the vessel was successfully stented and post-dilated, and the result is very good. There is still some moderate disease that is still left in the vessel, but clearly nothing further needs to be done. So this case has illustrated a few things. That sometimes, even though on angiography fluoroscopy one cannot see calcification, it does not mean that there is complete absence of calcification. And sometimes placing a balloon, and when you see a persistent waste, especially on a balloon that is appropriately sized to the size of the vessel, you can see a persistent waste which suggests that that the lesion is non-dilatable, and perhaps you can choose another device to dilate that vessel. This case also demonstrates the importance of intravascular ultrasound because calcification, dense circumferential calcification, was seen. The third thing is that the use of the lithotripsy balloon, which allowed this calcific lesion to be dilated, and then a stent could be placed appropriately. And finally, no matter what device you use, these calcific lesions are somewhat hazardous because both dissection and perforation can occur, and one has to be prepared to tackle those complications when you come across non-dilatable lesions. Obviously, this was easily treated with stent placement. So we know that calcification has an impact on how we treat these patients and how we prepare the vessel for appropriate stent expansion. And there are some non-invasive and invasive methods by which we can detect calcification in coronary arteries. There are some pros and cons to either one of, or either of any one of these techniques. Whatever technique you use, it is important to have a methodology that determines the extent of calcification and depth of calcification, and upon which the treatment choice is then made. So how do you detect coronary calcification? Occasionally, a CT scan is done. It's not a routine test to detect coronary calcification. In planning a procedure, it is done for screening purposes, etc. However, even though calcification is seen on a CT scan, the degree of calcification in terms of how deep it is, how superficial it is, and what the thickness and depth of calcification is unable to be determined with this technique. Obviously, we do fluoroscopy angiography when we do coronary angiography, and very often we depend on the appearance of calcific silhouette of the vessel to determine whether there is calcification or not. This is a very simple method. However, it tells you that there is calcification, but does not tell you whether it is superficial or deep. What is the thickness, what is the extent, is really not known. The important thing is most of us see this calcification on fluoroscopy, angiography, or CT scan. We have a low threshold then, therefore, to use plaque modification with either balloons, cutting balloons, rotation atherectomy, other atherectomies. And these instruments are close at hand when you suspect that there is significant calcification. Obviously, to plan the procedure, intravascular ultrasound or OCT are invasive tests, and they are the gold standard as yet to determine how one approaches these patients. They are able to detect the location of the calcification as to whether it is superficial or deep, and what the extent is it circumferential or what is the subtended angle of calcification. Now, occasionally, because of the vessel characteristics, either because the lesion is very tight or the lesion is very tortuous, and these are somewhat bulky devices, even though OCT is better than IVUS in terms of crossing lesions and tortuous territories. One can use a surrogate like we used in the other case. You can try to pre-dilate the lesion with a balloon, and the persistent dog bone appearance of the balloon will tell you that this is a non-dilatable lesion. This is an example of calcification that is seen on CT scan. This is the right coronary artery, and you can see that there is a lot of calcification. However, it does not tell you whether it is circumferential, what is the angle that is subtended, whether it is superficial or deep. So it tells you calcification, but does not really tell you how you can plan the procedure, except you have to have a low threshold for using plaque modifying devices. This is a silhouette of the vessel with a wire down the LAD, and you can see, this is not in motion, but you can see that there is calcification that is seen in this area. Again, like the CT scan, one suspects that there is calcification. However, one cannot really plan a procedure based on that appearance. Whereas this IVUS example that is shown here shows circumferential superficial calcium that is quite thick, and all of us know that such lesions cannot be easily dilated with just a balloon alone, and very often other techniques have to be used than just semi-compliant or non-compliant balloons. The IVUS also tells you the degree of calcification, in the sense that what is the angle that is subtended. So here you have a 180-degree calcification, and here you have more than 180-degree calcification, almost 270. And how you approach these lesions will depend very much on the extent of calcification. One needs to have a continuous run of this IVUS, because you may see various angles subtended along various segments. So a certain segment may have 360 calcification, and other areas may have less calcification. So you would always concentrate on the area that there is more calcification, deeper calcification, because then you are able to choose the appropriate device. Now the calcification can be either superficial or deep, and deep calcification is very hard to treat because of the fact that you don't have devices that extend all that way. So for example, rotational atherectomy or laser angioplasty or other devices, debulking devices, will not really work, but maybe lithotripsy in this situation may work, because whereas these lesions can be cracked with plaque modifiers, these lesions, the vessel does not dilate, and though you may get rid of some of this plaque, the calcific segment will not really expand unless you use something that extends into the deeper layers of the vessel, so you can actually crack that part of the vessel and expand your stent appropriately. This is the appearance of calcification on OCT, and unlike IVUS, it maintains the shadowing behind it, but the characteristic is that you have a very sharp demarcation. So you have sharp demarcation here and dropout of light back here, suggesting that there is calcification. It's a little difference. So which one should you use based on their characteristic? One can choose one or the other. I will not go through this. But the different properties of the IVUS and OCT are what dictate the appearance that you just saw. And these are some of the pros and cons of IVUS versus OCT. Again, don't really have to go through that. In my experience, either one is good to detect calcification, the extent of calcification, the depth of calcification. The importance of the presence of calcium is because calcium inhibits circumferential expansion of a stent. And the asymmetrical stent expansion is seen in up to 50% of cases where the stents have been deployed. That's not very good, because the calcium nodules will prevent expansion, and this graph tells you that the arc of calcium decreases the degree of stent expansion. So if you have close to complete circumference calcification, the stent expansion does suffer considerably. And that does increase the risk of in-stent thrombosis, restenosis, and of course the eventual mortality and morbidity. So this Kaplan-Meier curve suggests in blue that the presence of severe calcification results in adverse outcomes in patients all the way up to 3 years, whereas appropriate stent expansion with absence of calcification is associated with a much better prognosis. And this was a one-year registry. The previous one was a meta-analysis showing that moderate and severe calcification does have an impact on the eventual outcome of patients following PCI with stenting. How do you manage coronary calcification based on the appearance? There are various devices that one can be used, and the latest device on the market is the intravascular lithotripsy balloon. So based on the extent and degree of calcium, you can use the appropriate device. So my final 2 slides shows you this. This is a simple algorithm that I use when I see calcification. If you suspect significant calcification based on non-invasive testing or angiography, then you can try to pre-dilate the lesion with a small diameter semi-compliant balloon. And if there is dog boning seen on the balloon, you suspect non-dilatable lesion. By and large, in most cases, when you have severe stenosis, you do pre-dilate the lesion because you need a passageway to pass your imaging device. So you can use the appearance of the balloon then to decide what you need to do. If you do cross the lesion then with intracoronary imaging, if you're unable to cross it with imaging, then obviously you need to modify the plaque, and you can use rotational or orbital atherectomy, and then you can do intravascular imaging. And if you find that there is thick circumferential calcium with no effect on the calcification, then one can use intravascular lithotripsy. If it can be crossed with imaging after pre-dilatation, then you have to decide what is the arc and thickness, and based on that, then you can choose either high-pressure balloons or atherectomy or IVL. So this is how one can reduce the use of plaque modifiers, which obviously are expensive and need a certain degree of expertise to use. So intravascular imaging can help you do that if it indeed does cross the lesion. So the conclusion that I draw from this presentation is that coronary calcification, as I showed you, has significant implications on PCI outcomes. Both mortality and morbidity is increased if these lesions are not prepared well and stents are not fully dilated. So an intracoronary imaging is a useful tool in deciding how to treat these patients. There are multiple devices that can be then used to treat these calcific lesions based on your findings on invasive imaging. The atherectomy devices have been standard of care, but now the intravascular lithotripsy is a new device that seems to have an important role. Sometimes, like in the case that I showed, you have to use a combination of devices, and occasionally we have to use rotational atherectomy followed by the lithotripsy, etc. And when one uses such devices and in imaging in certain places, one needs to be aware of the costs that are incurred in doing such cases. That's the end of my presentation. I'll be happy to listen to any discussions that the panel may have.
So that was really a great presentation. Just as a comment, the last year there was a sub-analysis of Syntaxis trials, and they demonstrated that at 10 years the results in calcified groups and in non-calcified groups were different depending on the appearance of calcium. I mean, in the patients with severe calcification, there were at 10 years there were no differences in outcomes in surgery group and in PCI group. Surgery actually was not superior for the severely calcified lesion population than PCI. In non-severe calcified lesion, the surgery had a definite superiority than PCI. So this is.
There appears to be a paradox there.
Yeah, absolutely. It's really a paradox because it is expected that by bypassing the proximal calcification, you will have much better results with surgery, but it is not so. And this is regarding the most hardest outcomes. I mean, death
Right.
and cardiac death. This is not just some target lesion revascularization or so, which is, let's say, much softer outcome. outcomes, and but in calcified group, the mortality was twice larger than the non-calcified group.
Yeah.
And it was published several months ago, just.
As a comment, it can be different. I mean, probably the calcification in these people, which have more calcified coronaries, is in the reason for more fast degeneration of the vein grafts. This could be something, but really, calcium is a big issue, and the thing that we all address is that very often we cannot see it. In fact, calcified lesions can be detected in around 40% by angiography, and that's the issue.
Yeah.
And we can, there are some rules for using angio as guidance for how calcified is the lesion. And the one simple rule is that if you can see the calcium above and below the vessel, for sure it is heavily calcified and you should do something.
Yeah.
And probably what you propose is a very good algorithm, although not always suitable and can be widely used. I mean, using intravascular imaging to detect and decide the modality of calcified lesion treatment.
Right.
Thanks. That it was a really great presentation. Thank you, Ravi. I can see George. Can you hear
Hello,
us?
everyone. Yes, of course. I really miss not to be there, but hopefully we'll be able to meet soon.
Thank you, George, for being with us, even not face to face. We'll have the pleasure to hear your lecture about practical approach and basic approach to coronary CTOs. And I hope you'll be around us to discuss cases and the live transmission after some.
Yes, absolutely. It would
Today
be a pleasure.
and tomorrow.
Absolutely, yes, of course. I am here. Thank you again for inviting me, Valerie. This is the first time to miss it, but I promise you next time I will not. Special circumstances didn't allow. So
we're trying to find the compensation, George, that you should pay.
That's correct.
That's
correct.
a joke.
You know, the big prize is that I will miss the winery. So, and a very good friendship. As far as I understand, this session is about talking for fellows. So I kept it a little bit to the easy side. This is, I really followed with great interest the evolution of the talk about calcium, which becomes a prominent thing. And I had the opportunity the last 2 weeks to do quite a lot of lithotripsy, imaging, root ablation, orbital atherectomy, and all these kind of devices readily available where I am. And then maybe I will present you tomorrow the case of 5 millimeter calcified node cracking with IVL. The root ablation did nothing. So it becomes a very big issue, and a combination of calcium with, if I can make a commentary to the previous talks, and especially LVAD plus CTOs are really an evolving field that it comes more and more. And what I see from the talks over the period of time is that CTO PCI is evolving into perfection, preventing complications and increasing efficiency, because that's what I'm taking as a message from all of these kind of talks. Anyway, let me come to the topic of my presentation, which is the basic approach to coronary total occlusions. You see here an overview of the evolution of CTOs over time, from the single wire from the beginning of the interventional cardiology to the parallel wiring before 2000. The IVUS was guided in 2000, then the STAR technique that it was invented by Colombo around 2004. In 2005, the retrograde techniques came into the scenery and really revolutionized the field. And we have the subliminal space connection techniques, or the so-called dissection reentries, that they have that came around 2008. And there is a great evolution in all of these things as time is advancing, related to both technology evolution but also experience of the operators. As far as the topic is for fellows, many people are really, or the experts are really challenging anymore the validity of simple techniques like the parallel wire technique. Maybe due to the fact that the cases that they're dealing into the routine practice might not reflect the easiest of the stuff, and maybe the mind is really skewed by the complexity, because if someone is always into the JCTO score 5 every single day, then maybe parallel wiring is not a routine thing, but still very relevant in my view to many. And many patients will benefit from such procedure. You see here a bioradial axis, which is a standard thing of mine. A patient with an occluded CTO. This is an old case, but I found it illustrative. You see the calcification in the proximal LAD. And basic rules of CTOs, bilateral axis, double injection, it shows you the target very clearly. And you see support always with a microcatheter, in this case it's Flying Cross. And you start wiring. This is a Fielder XT. I don't use it anymore. I'm more into the direction of Gaia wires in the low range, Gaia first or Gaia next first. And the wire goes subintimally, enough not to reach the target. What you do in this kind of case, you see the first part is that whether you use dual lumen microcatheters today, which is the trend, or true dual lumen, like the recross, dual lumens are 3 or 5 anymore in the market, or you exchange the microcatheter, and then what you see here with a stiffer wire, essentially this 1 millimeter of difference, it shows also the pathway to success, avoiding complex techniques. And you see where the Fielder XT is and where the Confianza Pro is, and I think this 1 millimeter of difference is what make success versus failure. And finally, this case was extending into the left main. The ostium was not touched. Evar gave this exceptional presentation on complex left main techniques, and not only, but also with appropriate practice. Regarding the imaging, I have to say that I've been surprised myself after practicing all these years how much I really didn't know. I will come back to that. Certainly, I cannot agree on the lack of imaging on the at least left main PCI, mainly from experience that I got recently. That I've been practicing 25 years of left mains, but I really learned a lot in 15 days. So, history of retrograde approach of CTOs. You see here an overview. I will stop the antegrade only on the parallel wiring, learn how to do it right. And for the retrograde, I'm going to also talk about basic concepts, because that's the point of the discussion. We can go very deep in the field from post-cabbage, bifurcation CTO, through retrograde CTOs, double, triple retrograde axis, and all this kind of stuff. But people have to start learning the basics. And you see the key point was 2005, the CART, the control antegrade retrograde subintimal tracking by Kato. You see it here, essentially. This is a slide of him, 2005. This is what the CTOs that we're referring to. It's not the type A CTO or the very short, long, with some bridging collaterals. Antegrade tracking as far as you can go, and then this is the old good time that you are crossing the septals with balloons and dilate the distal cap, and you see that the antegrade wire jumps distally, and then the conclusion of the intervention. That's the classical CART. You see it here. I will not go into the very details, but essentially the balloon dilates, creates a space for the target, whether antegrade, which is CART, or the retrograde, which was reverse CART after the advent of the microcatheters. And then you're having wiring antegrade or retrograde. Any steps that you have to do it right, I'm not going to do the detail. what is very critical for these kind of cases is the analysis of the film that you really have to see what you're doing, referring to the proximal cap, the distal cap, the axis of collateral circulation, make a planning of the procedure. I'm just going to show you only one film that has it everything. This is an old film from India. I have it for 3 or 4 years now, but it has it all. And every time that I see this film with the evolution of the film, I understand it a little bit better, or based on the result I'm going to show to you today, I would have done the procedure completely differently, because this has it a little bit of everything. It has a lot of calcification in the LAD. It has a serious left main disease involving its 1-1-1 bifurcation. It has a good occlusion of the LAD, of course. This was done acutely, part of a meeting. We were expecting to do a live case, and then this patient came unstable. So we did it live, and you see the injection in the right coronary artery, showing the LAD. After reviewing this case, as the time was going on, we decided the family refused completely surgery. It's quite common in these countries. And then we decided to take the case and do it live. You see here the approach. The key point here is as I'm going to tell you, the collateral circulation was readily available. We knew that we were going to cross one way or the other. Septal surfing was performed. You can see filter wire going retrograde. And what this shows you is that the wire really crossed the smallest of the septals. There were far bigger septals to cross. You pay a price of this, because the more you cross the bigger vessel, the smaller vessel, the less successful the microcatheters are. But it had also an advantage, because you see here in the right panel, where we were pushing the Corsair to go, and it wasn't going despite the good support with an AL1. The wire is coming back, and then when we were releasing a little bit the Corsair, because it wasn't crossing through the septal surfing technique, you see gradually here at the wire, and that's just the filter FC at that time. It's going down, it's crossing it means that there was a channel over there. It's heading up to down to the circumflex, and then you see this wire has been manipulated and reached actually the left main. And this is why I'm showing this technique. I'm not going to go into more complex technique. I'm not going to show any more reverse cars or whatever. I just want for the fellows to keep the basic thing that a good 25 to 30% of the retrograde cases are true retrograde wire crossing without any much more to that. So you see, you enter the guiding catheter extension. Then what you do here, the guiding catheter, what you do here is that you trap your retrograde wire, and you have the power to advance your retrograde microcatheter. You will see it here, quite a lot of calcification into this LAD. You see that these microcatheters are excellent, and tomorrow, because I have the talk about CTOs and calcium, I will present you only 2 cases of the last 3 days tomorrow, just to show you the evolution of the things. And then the microcatheter is crossing. I will not go into the details of this procedure, but anyway, the left main has been fixed after externalization. And today, what I would have done different, mini crush technique was applied, as you can appreciate here, but you see that the LAD is not fully expanded. At that time, it looked great to me, but today, this result that you see in the ostium of the lead, especially with this calcification, is not acceptable. Completely different things I would have done today as compared to 3 or 4 years ago, which shows the evolution of the field in the perfection of these procedures. Because the better you do them, is not about the acute outcomes, it's about the long-term outcomes. And I think there is where we are targeting anymore. Anyway, you see this standing was performed. This left main looks good. Certainly the ostium of the lead is not where it should be. And then that's the final result of this intervention. So pure retrograde wire crossing, keep it as a marker of who we're stenting. I'm going to give a little bit of perspective of the dissection reentry techniques, because in my view, despite that I'm not really a very big fan of them, I think it's a field of a great evolution in the CTO PCI. The basic categories were based and device-based. The classical star of Antonio Colombo, not in use anymore. Not because the concept is not good, but it has been refined. It's the mini star and the last technique. Mini star is referred to the fact that you cross the body of the occlusion with stiff wires, and then you're making the re-entry with soft wires in a knuckle fashion. That's what Ministar is. And you have the limited antegrade subintimal tracking, whether you're crossing the entire body of the lesion with soft wires in a knuckle fashion. It's a fast track US approach, I would say. I tend to appreciate more of the time, but not completely agree on the concept. And then you make the re-entry with stiff wires plus devices like Rosebos. And you have the most, which is a nice concept, the AFR or STR, the antegrade fenestration re-entry techniques. This is the concept of the re-entry device based. Whether you go, mostly this is what I call the limited antegrade subintimal tracking device based, that you cross these long occlusions with knuckle wires, and then you use this balloon that's like a leaf, where it's orientated in itself in the inflation, and then you make the re-entry with stiff wire puncture, and then you take this pathway with a softer wire. I'm not going to give you an example of that because that's a little bit more advanced than the field, but I would like to show you this device, which is simple. Essentially, is a dual lumen microcatheter with a balloon on its tip, and it's quite effective. And I'll show you an example of that. It has to be applied in the cases that it should be. This is a courtesy of Freddy Galassi case. You see a right coronary artery, and not very good collaterals, not impossible, but not very attractive. In any way, this case in today's hands is going to be successful one way or the other. But look at that, what is the case here, and that's what we're talking about. That's what I'm telling you. This is the baseline thing, that you go down knuckle fashion in 5 seconds. You advance the microcatheter, and whether at this point you do any kind of device-based re-entry or whatever I'm going to show you now, this is the concept of what we are calling anymore wire-based dissection re-entry techniques. You see it in 2 projections. You advance the microcatheter, and then you bring this device here that I show you, the balloon. You inflate that, and then you have the second lumen. What are you doing essentially? You're cracking the distal cap in a more predictable way, and then the second wire is usually kind of a run-through, kind of a hydrophilic normal workhorse wire. And then through these cracks, a kind of simple wire. If you crush the distal cap, then essentially you create connections with the true lumen. That's the concept of what we're calling antegrade fenestration re-entry, and you can appreciate it. Here. Anyway, I'm going to close this talk. I'm going to stop here. I showed you an example of parallel wiring, the basic concepts of the retrograde. It's important to analyze the collateral circulation, proximal distal cap, and also a little bit of the modern day dissection re-entry techniques. I didn't insist on the device-based too much, except this simple balloon, and there are many devices you can do the re-entry today. The milestones a little bit. I close the presentation with a few slides about the materials. Microcatheters and wires are cornerstones as we're talking today. 99% of the business is based there. And just for historical reasons, I'm telling you that the coatings and polymers are very important for wires, that someone has to know what is a polymeric coating, what's a hydrophilic coating. Cannot analyze all these things in this concept, but and then in the history where the incremental tip load, like the Miracle family, the taper tip design, and the wires that was the guidance wires, and then the CrossFit, and then the Aside Confianza that put all of these things together. And in 2008, we understood that not all CTOs are very stiff. So the very stiff wires, they have penetration capacity, but they have no deflection. So very soft wires, like the field RFC, happened. And then we realized that also very soft wires are not very good because you cannot do direct tracking. They may where they may go. And then after 15 years of working with CTOs, we understand that the truth is somewhere in the middle. And then the Gaia family was developed, which is wires in the intermediate stiffness with specific way of tapering. So it's not this complete tapering that the Confianza had, but there is a gradual tapering at the end of the wire. You have a snorkel. And these wires, they have the penetration capacity because they have a conic tip. I'm not going to go to the details. So they have penetration capacity, but they have the ability to deflect. So this is a little bit of an evolution in the wire technology. I'm just going to show you here. You keep that mainly as an image in your eyes. About the evolution, because the technology has evolved so much that essentially we went from a single wire codec to the multi-wire codec, and then from instead of having a single wire, you have wire ropes anymore, and then you advance the technology from OCT1 to X-trans. So essentially you have wires today like SU03 that they have 20 wires in one single tip of a single wire, 20 components, and that's amazing what technologies has achieved in the wires. A specific dedicated wire talking might be necessary, but keep it that the CTO wire technology has dramatically evolved, helping things. At the beginning, as I showed you some case of some catheter 2005, there were no microcatheters. Then the Fine Cross came in the market, and then the Corsair, and today we're standing somewhere there. And this is not even the most fully updated slide, but you see that there are around 25 microcatheters in the market with different characteristics, big, small, angulated, dual lumen, plug modification. There are many of them. The message that I have to give you is that they are complementary rather than competitive, and we have seen any one of them failing and the other one succeeding without having any specific reason for that. And many of them creating complications and many of them solving them. So in that respect, keep that in mind, that we have also now here 5, 6 different dual lumen microcatheters. True dual lumen, this is the only one in the market, the Recross. This is a device that can be used for re-entry. This is essentially not a dual lumen, but a true dual lumen microcatheter all the way with 3 exit ports, so 2 over-the-wire lumens tip to end. Very useful for parallel wiring, but also for re-entry. Getting catheter extensions, trapping devices, that they become more and more relevant as biradial approach tends now to become standard in CTO PCI, and 6 French catheters are more and more in use, and these devices really help for trapping and using big microcatheters because these trapping devices are miniaturized. So if we take it all in all, and I'm closing after a short exploration of the CTO toolbox, where are we standing? Essentially, someone, if he wants to talk about CTO PCI today, he has to talk about 2 concepts, the wire escalation and the dissection theory techniques, so undergrade or retrograde. And if you pull all of these things together, essentially you talk about ADR or RDR, and undergrade wire AWA and the RWA, the dissection re-entry techniques on retrograde. Again, since 2014, this is the American algorithm, and then the EuroCTO kind of algorithm. I don't believe in this much. Even the authors that they write them, they're saying it's too complex, too dizzy, but it's important. And the message that comes out of these things, and there is the Asia Pacific now and another 10, is that the community put a big effort in education. And today we have global algorithms, which are important for someone to start understanding where the field is standing, and then when individual experiences really getting bigger, then everyone becomes what he may be. And that's my message when I'm doing teaching. You will become based on a little bit your teachers, but based on your character mainly. Where is the benefit of the CTO is about what I talked at the beginning, and what you talked through entire session now is the complex high-risk indicated procedures, the JIP concept, where you take into consideration about all of these things like patient comorbidities, the complexity of coronary artery disease, and very importantly, left ventricular assist device. I had the opportunity to do around 10 cases in 15 days now with any kind of valve you can imagine. And you can understand more and more the concept of assist devising in the field. The point is that complexity of coronary artery disease and trying to achieve revascularization, you see that these 2 things, we're talking about the calcium, it's a very big evolution in CTO PCI, the left ventricular assistance, and the chronic total occlusions at the top of the pyramid. The left main anymore is, in my view, is a commodity. Every interventional cardiologist, plus the bifurcations, of course, he should be able to provide it in a high level. The rest of the things is more complex, because they are not related only to an individual experience as an operator, but to the level of the institutional setup. Because you cannot exist for the desktop without really having structured programs. CTO is not a game. It became a little bit of a game in the hands of few people, but they understand better now that it's not only for that. And when you put it into the right perspective, then you understand that how serious into the treatment of coronary artery disease in combination with other it is. Thank you for that. That was the talk.
Thank you, George. That was really an excellent presentation, as always. But the things that you've showed us is not for fellows, I suppose. The cases, I mean, as always, amazing. I think that we should discuss probably several minutes until the patient is on the table and we're ready, especially in the new.
Yeah, I have a question. Thank you for your excellent presentation. Because it's a fellow dedicated session, I want to ask you, how, if I'm working in a facility without a CTO program and I'm really interested in the CTO PCI, how to develop a working CTO program to start with simple cases or to ask proctors to come for failed cases. What's the proper way? What's your opinion?
Yes. So as I said in my last closing the case is that CTO is a program and the operator and the build-up is part of it. So essentially what you have to do is that you have to sit down with the people that they have the power in the department and discuss whether you should build it up or not. And after, if the decision is yet, you should discuss about the level that you're going to build it up. So essentially it has to be what kind of service you want to provide if we're talking about an institution. Whether you decide after that, depending on the level that you want to put it, and you put yourself into this system. And this has two steps. The very first thing is that you can try alone, because in the modern day PCI, you don't need proctoring for everything. CTO, simple CTO, you have an 80% plus success rate with the very basic things that everybody knows. Everybody knows how to use a small microcatheter, and if you have the basic knowledge of some wires, even the non-CTO wires, take your regular wires and use proper setup. Everybody can puncture to groins or to radials. Then you start from that and you do the cases that you are expected to have an 85% success rate, because patients tend to go home. You have to respect the patient. When you start doing these things, you will build up very quickly the experience of the basic CTO PCI, and this will create the answers that the questions actually that you have to ask yourself. When you reach that level, essentially, again, you say, okay, do we want to go further, or are we going to be the center? Because it has to do with expenses. I mean, me and Dr. Gelev, we've been friends and working together for 15 years, and he knows exactly, as a director of a big institution, the financial burden in brackets of offering such a service. After you make these decisions, and that's what I'm saying, you say, okay, I have a department, I have a director that he decides to go, we're going to offer this service, we're going to be a referral center, and then we want to grow, and we're going to go all the way down through antegrade, retrograde, ADR, and all these kinds of stuff. And essentially what you need to do, you're going to make friends. That's what the most important thing is. You're going to make expert friends, that you're going to visit them, you're going to pay them a visit in the institution, you're going to follow a couple of big international meetings, to make the connections, and after you build up the program, because the build up the program means that when you invite someone of an expertise, out of respect to him, but also of respect to your patients and yourself, you will have everything. And then actually you will be proctor for a number of cases with the right person that fits your personality to train you, and maybe not only one. As I said, you might invite a couple of people that you respect and you know, and they will decide to come to you to essentially train you, and then through this process, actually you will get the mental maturity to move on and do more cases. And this is a process that will take a lifetime, because there are cases that I'm inviting other people to do with me. Not because I cannot get, but because I'm interested in the way they look the corners of the business, and then essentially that's the pathway to go on.
Thank you. Thank you for your answer.
As a comment, having our experience, if you do all the things that are well known, and these are the rules in just engaging with the CTO, wires, microcatheters, dual woman injections, and so on, and get and select cases. What we have in more than around 2,000 CTOs that we have addressed with George too. Cases which JCTO score, we have a very good, not perfect, but I think a good classifier of the complexity of the CTO. Cases with with JCTO score 2, let's say it's on the edge, but which are higher. This is, they for sure should be, you should consider the retrograde approach. So if you start with a more, not that complex, simple cases, 0 and 1, the success rate is around 70 and even more. And George is right, if you put a patient on the table, and this is the concept, I think, that is, we have it in the EuroCTO Club, your success rate should be around 70 or higher. The expected success, because otherwise it is not justified, and it is not fair to the patients. If you put a patient with expected success rate less than 70.
Okay.
And it's not only the success rate, what I didn't talk in this case, if I just complement the voice of Dr. Geller. And we know both of us together because we've done so many cases, and we've seen the best and the worst. Complications are part of the game. CTO-PCI has increased complication rates, we know that. Part of the expertise is really to avoid them, because success is one part, but not having very serious complications is another part. And complications and coronary of CTO, they go together. And you don't want to learn the hard way, I promise you.
Thanks, George. Thank you, really, that was great presentation, and your comments were very valuable. So we're continuing with the program, and the next thing is the first wife case, which as a tradition is going to be done by, let's say, our fellows. They are not fellows, they are anymore. They are our colleagues that grown up and with experience, and of course with years. And now we're going to present the case. And I hope, George, you stay with us and comment some of them.
Thanks,
George.
George.